I would like to thank Dr. Bada sir for providing me this opportunity to talk about role of imaging in carcinoma esophagus. So, so there are four types of esophageal carcinoma. Those are infiltrative, polypoidal, ulcerative, and spreading, superficially spreading types. Among them, the most common is infiltrative type. As we know, there are two most common types of esophageal carcinomas. One is squamous cell and other is adenocarcinoma. We know that squamous cell carcinoma is the most common type, but due to increase in the incidence of gastroesophageal reflux disease as well as Barrett's esophagus in the recent times, the incidence of adenocarcinoma is increasing in the distal one-third of esophagus. So coming to the routes of spread of CA esophagus, one is direct spread. Because the esophagus lacks a serosa, and it is covered by a thin loose connective tissue called adventitia. This promotes early and rapid spread of primary carcinoma to the adjacent structures. And esophagus is very rich in submucosal lymphatics. That's why we see very common lymphatic spread in esophageal CA. And esophageal CA show distant spread to the liver, lung, bone, adrenal, pleura, peritoneum, and brain. The most common clinical presentations are dysphagia, which is the most common one. Other ones are odonophagia, anorexia, weight loss, and symptoms due to involvement of adjacent structures like trachea, which might cause dyspnea and hoarseness of voice. Other acute presentations might be because of the development of fistula between the esophageal carcinoma with the surrounding structures. Before going ahead with the role of imaging in CA esophagus, we have to know about the staging. The common staging which we use is TNM staging, and this is the 8th edition of TNM staging right now, which we are using for esophageal carcinoma. And the T1 is involvement of lamina propria and muscularis mucosa and submucosa. T2 is involvement of muscularis propria. T3 is invasion of adventitia, and T4 is invasion of adjacent structures. Among them, T4A is the involvement of resectable surrounding structures like pleura, pericardium, azygous vein, diaphragm, and peritoneum. And T4B involves the invasion of adjacent structures which are not resectable, which are aorta, vertebral body, and trachea. Lymph node involvement, it is according to the number of lymph nodes involved, and M categories, whether if there is a distant metastasis, it goes into the category of M1. This is a pictorial representation of the involvement of this thing. The involvement of esophageal wall. So T1A is the involvement of muscularis propria as well as involvement of lamina propria as well as muscularis mucosae. T1B is the involvement of submucosa. T2 is the involvement of muscularis propria, and T4 is the involvement of T2 is the involvement of muscularis propria. T3 is involvement of adventitia, and T4 is the involvement of adjacent structures. This is the nodal metastasis. Is just a pictorial representation of the stations of loco-regional lymph nodes for esophagus. So, distant metastasis is because of the hematogen space to distant organs, which defines the M classification, which is a very important factor in determining the operability. So, coming to the importance of EUS in carcinoma esophagus, it allows very precise staging. As we know, on EUS, we can make out the layers very clearly. The deeper one is the hyperechoic layer, which is lamina propria. Just outside that, we see hypomuscularis mucosa. Outside that, we are seeing hyper submucosa. Then we are seeing hypomuscularis propria, and then we are seeing hyperadventitious. So these alternate hypo and hyper layers. So by EUS, we can know the depth of invasion of the CA esophagus with absolute precision. So the sensitivity and specificity of EUS is almost 80 to 90% in knowing the depth of invasion of the CA esophagus. So it's a pictorial representation in the right upper image. You can see there is involvement of submucosa. The left lower thing, you can see there is an involvement of muscularis propria, and right distal right lower picture, you can see there is involvement of adventitia. This is the proper EUS image, which shows that there is involvement of submucosa here, which is a T1B lesion. Outer layer muscularis propria is well preserved. So EUS has a sensitivity of 59 to 97% for end staging, and specificity of 40 to 100%. 100%. The presence of hypoechoic appearance, size more than 10 mm, and absence of central intranodal vessels predict the malignant lymph nodes with an accuracy of 80%. And this accuracy increases when we do EUS guided fine needle aspiration, where the sensitivity specificity increases to almost like 90%. Even with EUS, we can see the metastasis to the liver, pancreas, and adrenals as well. What are the limitations of EUS? It is operator dependent. Visualization of primary lesion and lymph nodes may be challenging in the background of near complete to complete stenosis and post-radiotherapy fibrosis. And due to its invasive nature, there is a potential risk of complications like perforation.